Great. Welcome back to Healthcare. And we are now going to turn to S65 that we took testimony on last week and have a discussion about if we want to move the bill. And I'm going to turn it over to Representative Black.
Sure. So I think, let's see, it's Tuesday, the 18th that we took testimony. We had Blue Cross Blue Shield, representative for MVP, healthcare advocate, I believe. And just sort of wanted to get an idea of what everyone was thinking, if they had thoughts on it, whether it's something we want to move on or maybe make changes to. Oh, remind you that it's S65. It is the commercial insurance coverage of epinephrine auto injectors. So essentially the bill was making it so that there would be no cost sharing for patients for epinephrine. Brian.
It might be a question for legislative council or anyone who remembers that. What was the fiscal impact they said of doing this? What was their estimate cost?
I don't think they gave one.
I remember it being a very narrow portion of the population that it would impact.
Yeah,
right?
it was like 50,000 or something. They said dollars. That's why I don't want to put the number there, but I feel like it was a small number when they said it. But I'm just curious what anyone remembers.
Without the healthcare folks here, it's tough.
Well, Blue Cross Blue Shield did say that right now their tier 1, which is the generic version, is covered at 100%. So those already have no cost sharing. We did get additional written testimony.
I can look it up and then.
That the average copay across their entire membership, $9.82.
Yeah, I'll say it.
For it.
Yes.
That was my question is why is this a bill is it like, how many people will this serve? And like, just curious as to what the genesis of it was.
I mean, not being in the Senate and it was a Senate bill, I think the current concern is that there are people who do have to pay out of pocket the whole cost. But I believe we took testimony that those are the people that are on the high deductible health plans, which this bill does not change.
Right, that was my understanding.
Yeah, right. That would not change the high
It would not change
deductible.
the high deductible health plans.
Right.
Oh, Leslie.
Thanks. I think in the Blue Cross testimony, they raise a question that is similar to mine, is why single out one drug? And that's what I'm trying to understand. And once you start doing that, it sounds like a slippery slope going down to whatever drug the drug of the day, as it were. So that's a question for me.
I'll do Mari and then Art.
Now that the prices have gone down, I think it may not be an issue, but who knows if they're going to go back up again. When I introduced the bill last biennium or the biennium before, it's all running together, to limit out-of-pocket costs for insulin, we talked about, we being the people interested in this, adding respiratory inhalers, because those are also very expensive, and EpiPens. There are particular medications that are life-saving, EpiPens, insulin, and respiratory inhalers that are a little different than a lot of other medications because they are often emergency meds, and people will die a lot quicker if they don't have them. So the intent was to remove barriers to access. That being said, would it be worth hearing from the sponsor of the bill?
We can. I mean, I'm not sure we really need to understand the intent, because we know, the intent is this would affect a small number of narrow people. who would be able to have this at no cost share. But yes, I mean, we can have someone come in. Can I just throw in only because so there was a question about the fiscal note, and so I just looked on the Senate. So there is a fiscal impact of 25,000 to 30,000 annualized because of the state of Vermont employee healthcare plan.
That's what it was.
So that is, and then, no, that's no longer good.
For the record, Amber Navajuli, Legislative Counsel, that was a fiscal note based on the coverage applying to the state employees' health plan. But as passed out of the Senate, it does not have that, so.
Okay. There's no fiscal impact. Thank you.
No
But
fiscal.
that's what you were thinking. I believe if you look at the letters from Blue Cross Blue Shield and the MVP representative, you'll see they do, in a very minor way, address what the cost impact might be, which is not a lot given the low utilization they're anticipating.
I don't know if my notes are correct, but I have here like less than 1%.
Of people who use.
Art?
Yeah, I have the same concerns Leslie does in terms of, because it's a relatively small amount of money, let me rephrase it. Because most people are paying, sounds like, $10 roughly, unless you have a high deductible. That to me doesn't seem like a burden. Maybe it is, I don't know, but if we start giving this drug away free, where does that stop? That's my only hesitation. Maybe somehow putting frameworks around this might be something we can do, a limit. I don't know if that makes any sense at all, but I don't know. That's where I'm at.
So in talking to legislative counsel, and maybe Aaron can fill us in. Currently, we cover contraception at 100%, but not all contraception. And in statute, isn't there a requirement that they must cover at least one type?
Yes, that's correct.
So, I mean, that is something that we could consider. So instead of, go ahead, Leslie, and then I'll give a thought.
Well, I just wanted to say that I think Maury makes a really important point about emergency medication that saves lives, like insulin and inhalers. If there was a bill looking at medication that saves lives, then that would be different than one specific medication. And I'd be much more interested in thinking about that. So I don't want to ignore Maury's point because I think it's important.
Right, so we don't have that bill in front of us. Be happy to take it up if someone drafts a bill like that.
Is it, I'm sorry.
No, I wanted to put out there my concern, not only why single out just this one drug, but my concern is, if you remember in the testimony, there are generic versions.
Yeah.
And then there are name brand versions. And now there are some new different versions that have different types of delivery systems. They were talking about one, I know Blue Cross Blue Shield mentioned one that they actually don't even provide coverage for. And I think it talks to you and talks you through the process. My concern is if we did this bill as is, we would essentially be telling the insurances that they must cover all injectables, all self-injectables this way at 100%. And that what would be stopping people from, okay, I'm going to refuse the generic now. And I'd like the new, the new technology ones. And I'm worried that would really increase the cost. Which is why, the concept of, we could make it so that the insurances would have to cover at least one drug within this category at 100%. And that would go to the life-saving measure and address some of the concerns. Brian, I'm sorry, I had interrupted you, but you can go ahead.
You didn't interrupt me, you went before me, that's okay. I reread both of the letters, which is good because it's sometimes easier to read something after and process it than when someone's talking. So I read them both and the most compelling argument against it for me is something that came up in this discussion, which is the policy decision to decide that one life-saving intervention deserves treatment separate from others. And they talk about how preventive care, there's this consistent approach where like certain contraceptive and preventive care is covered under Vermont law, but that emergency interventions like an EpiPen, we're singling that one thing out. So I would lean, if there isn't urgency to pass this because it's a small amount of people it would affect, and most of them are, what it would mean is people paying less of a copay, and not that they're not going to have it. Then I would lean more towards waiting and taking more testimony over the next year on the issue. And if we need to introduce a bill, we do it, or if we can use this one as a vehicle when we expand it. But I would rather the only thing I could see doing with this would be like some kind of, which I know is not popular, is a study where we say to them, come back in January with like a list of the emergency drugs that are on par with this and the amount you spend. So then we could look at that and make some decisions, but that might be too much to ask or to do in the last minute. But other than that, I would lean towards looking at the bigger picture and seeing if there's something, because some of their arguments about like MVP explained here that their rates went 20%. Remember I was complaining about my insurance going up? It went up 20%. It was pretty significant. And even though this has a small impact on that, every little thing we do affects that. So I think that is something we have to be careful about. And they also pointed out a thing that got by me the first time around. This is in the MVP letter, which says there's actually tax consequences for people that when they waive cost sharing for a non-preventive item before the member satisfies their HDHP deductible, then they aren't eligible for the pre-tax health savings.
Yeah, the HSA.
Yeah, so they lose something, and I just don't know like if people will know that.
Well, also this bill, actually, those people are not eligible for the no cost share.
Wait, can you say that last part again, Brian, the last statement you said? Who's not eligible for it?
I'll read what they said, and then I might have looked at the bill before the Senate amended it, so I didn't realize that, but that it says, what are the tax consequences for MVP members in HDHPs if MVP waives cost share for epinephrine auto-injectors? Under IRS regulations, if a health insurer waives cost sharing for non-preventive items, including epinephrine auto-injectors, before the member satisfies the HDHP deductible, then the member will not be eligible to make pre-tax health savings account contributions to their HSA. The contributions become taxable and the members lose their tax advantage. So that's sort of like that could be an unintended consequence of us doing this that people would need to know. And I don't fully understand, like maybe you can explain better.
Well, for the record, Amber Energy Legislative Council, the as passed by Senate version specifically excludes the HDHP from this mandated no cost sharing requirement exactly for that reason, to avoid that unintended consequence. So on the plus side, those members who are in high deductible health plans are able to keep their tax savings through using a health savings account, but on the flip side, they're not then able to take advantage of the no cost sharing.
I see the change now. I was looking at the wrong one, so I have the correct one in front of me.
So that was correct in the as passed by Senate.
That addresses that piece, but I still think whoever was saying it in our discussion, because now it's a blur, about looking at the bigger picture, I would lean towards looking at the bigger picture, because like maybe we could talk with insurance companies about, is there some way to look at how to make emergency interventions more affordable? All of them, like, I don't know. But the only reason I would do this is because I do feel like the way things work is we pick away at it. It's sad, but it's like this year we do this and this year we do this and we slowly increase access that way, but it would be better to do it in a more holistic way.
All right.
Couple of points, just a reminder that when the cost of health benefits goes up, the single largest driver in that increase is pharmaceutical. So it's a little tricky dealing with that and, singling out. The PBM bill has a section that we've taken no testimony on, so I'm not saying one way or the other, but it does include creating or moving towards creating a wholesale, Vermont having wholesale capacity as a state and lowering the cost of medications that way. And so there may be a vehicle in the PBM bill to address some of these issues.
To Brian's point, does anyone else have any thoughts on, could we actually be creating harm in doing this? What are the unintended consequences? You talked about the unintended consequences with the high deductible health plans, which it sounds like the Senate addressed, but if we do this for this one drug, what are the unintended consequences?
I think one was already mentioned, right, where people move to the higher drug, the higher priced one, because they now have no cost share, and then that really drives up the cost and potentially the premiums for others. Yeah.
And I think we did hear one of the insurance companies say that if someone needed the non-generic and there was a reason for it because of some sort of chemical sensitivity, that they could get that covered or waived, right? Did we hear that? So it's not like we're not getting options. There's still a mechanism to get that if you need it.
Yes.
But not making it open to everyone.
Art?
The cost of these, well, the average cost, they said $9.80. But is that the cost that a person under these plans would actually pay for the item? In other words, if you have the health plan, low deductible, not high deductible, you need this and go get the prescription, what does it really cost the person? Do we know that?
That $9.
$9.80 is the
80 cents.
average.
That's what they're saying.
That's what they're saying.
The
Okay.
average copay.
All right.
So that's the average cost
And
share.
insurance picks up the rest with premiums and all the machinations.
Yep.
See, to me, for a year, now, assuming that, all right, now who needs these? And excuse my ignorance, but the person that has the problem, schools need them. Who else needs them? To keep someone safe from having a problem. I mean, any other place? I mean, restaurants have them.
Who needs EpiPen?
Yeah. Yeah, well, I didn't know. It helps them. I don't know about anything
A lot
about
of
it.
people who run schools, people carry them with them. I know multiple individuals who have to carry them with them.
Right.
Sometimes, I know one person who carries 4 to 6 EpiPens because she's already died once, so she's got to act really quickly when she has an episode related to her allergy, and she has another underlying condition that makes it worse. So, yeah, I would just say that there are a lot of individuals in a matter of minutes, they could die if they don't have an EpiPen, and it happens on for some people, almost a daily basis.
Almost daily?
For some people, yeah.
Really? Okay, so this can amount to a fair amount of money for some people. Even at $10 a shot. Okay. I didn't know, I thought somebody had it, if you got a bee sting by chance over the course of a year, then then you get rid of it, get another one in case you get a bee sting. I mean,
That happens, that's part of it, but there are like, I don't know the numbers, I could look it up, but there are many, many people in Vermont and in the US have autoimmune diseases and other types of diseases. Mast cell is one of them, where their body responds out of proportion to sometimes they don't know what, and they'll just immediately go into anaphylactic reaction. And they live their lives that way, knowing that at any moment.
they use these things relatively regularly.
Yeah, it could be once or twice a month, but very regularly.
Could we get data on that? Could we figure out how many of these are used here and, you know?
I mean, you can, I've got Google up now, I just haven't gotten very far into it,
But I would also remind everyone, you're talking about the broad population that uses them. But we're talking about a very narrow population of Vermont that we would be looking to get this on.
I wanted to go to Brian, but I wasn't sure. Bobby, had you had a question before?
Not on this particular thing?
Oh, okay,
No, I didn't raise my hand.
okay. Brian?
Yeah, just, or like what you're saying about how like some people might need to use it regularly. I'm sympathetic to that. Like, but I think what's the difference between that and somebody who needs to take another medicine multiple times a month? Yeah. I'm not saying this is, but I'm just thinking, that's my thinking. It's like, and in the end, like I have a really high deductible, which makes me not use my healthcare, which is unfortunate. But my understanding is that if people are paying for these, cost sharing, doesn't that count towards their deductible?
Yes.
So it's not like I'm not dismissing that because that's a big deal. Like I don't even use my health insurance because I don't want to because of the financial implications. But I'm just thinking like, it's not like, there isn't a cap, whereas like if someone has if someone has a disease where they are needing to use these twice a month and go to the doctor all the time, I hope that they have talked to the healthcare advocate and have like the best possible plan for that. Cause I know like when I went to them, they were saying like, for some people it makes sense to get the silver or the gold because they use it so much that the tax benefits, like in terms of like the credits the feds give back will make up the difference and that it's better for a person. So I guess what I'm getting at is I hope that people who are needing to use these that much have talked to the healthcare advocate and know what the best plan for them is, because in the end there would be a cap like that if you have the right plan. But I'm not dismissing the unaffordability of things because it's horrible that people even have to like worry about, going to the doctor or getting an EpiPen because of the cost.
And I did just forward, I had asked Sarah Teach out approximately how many of these do they pay for in a year? And I did just forward that email to everybody on the committee. And she said that in 2022, Blue Cross Blue Shield paid 1,620 claims. So total.
But that's not individuals, those are claims.
Well, prescriptions, they filled.
But that could be more than one a person.
1,620. Could be more than one a person. So 1,620. And I guess the only other thing that I wanted to say was in Sarah Teach out's written testimony, there's also the part about the required AV value, the actuarial values, and that these health plans have to have, these insurance plans have to have cost sharing. And every single time we eliminate cost sharing on something, they have to find cost sharing on something else. So, they're working with a balance where under the ACA, these metal level plans have to have a certain percent of cost sharing. So every time we eliminate something, something else is gonna get it. So Anybody else have anything else they want to add?
I think we have more information to find out about this thing.
I kind of feel the same. And I think the information is like, I don't fully understand the driving need for this. It would be interesting to hear from the sponsor of the bill, maybe. I think we've heard from people who are, providing the drug, but I'd like to hear from either the patient advocates or the sponsor of the bill on why it was introduced.
Can I mention a text message from the sponsor of the bill that I just received? That she can come in and testify if needed. As someone who has insurance and uses EpiPens, I assure you that they are not free to meet. The last one I picked up cost me $556.
Oof.
So we might benefit from hearing more.
What kind of insurance does she have?
Yeah.
We don't need to put that out there. Right, that's the question.
Yeah, that sounds like a tier 3 EpiPen though, based on what I'm seeing.
And I also wonder, Art was asking about, where are they used? Childcare centers probably also carry them. I know in my daughter's classroom, like peanuts are just, you can't get them anywhere near the front door. And if those are, as I think someone testified, like sometimes the children's doses are specialty ones, so those might be the higher priced ones. And so, I think that's a conversation that I want more information for.
So I'm not sensing great enthusiasm. Maybe gather some information over the next year and.
Punt this, I say we punt this to next year based on what I'm hearing. And having Tanya come in in June.
If I could hear from Tanya first.
Yeah.
I'm okay with waiting to act on it, but I do have enthusiasm. I just want to be clear. I have enthusiasm about the idea of looking at ways to make emergency interventions more cost effective for people in a way that doesn't hide the real cost, like the concerns they have. But like Mari mentioned, there might be another vehicle for it, like through the other work we're doing around prescription drugs. But I have enthusiasm. I want to be clear about the issue. I'm just not sure if this is like a Band-Aid on a bigger issue that we could actually get to in the next year in a more meaningful way.
What would be the bigger issue?
Making sure that people have greater access to emergency interventions, emergency pharmaceutical interventions, like an EpiPen. That's what we're talking about now. But like we were saying, like there may be other things that we're not giving this benefit for. And without knowing the bigger picture, why would we choose one little thing and not help everyone if there's something we can do that might help everyone? And Mari was saying in the pharmacy benefit manager bill, there's a section that we might be able to work with that could do that. So.
Could we, before we say commit to moving it to next year, could we have a brief conversation with Tanya? Yeah, that's what I would like to. Sure. If it's as simple as, like, she might have a simple answer for us as to why this is really a standalone fix that's needed.
Yeah, okay.
And this might be something for next year, but just if there's ways, especially with the life-saving meds that we're talking about, is there any mechanism to get the high deductible people inside the, and I just don't know. There's no way. It's a federal thing, so there's nothing that we can do. I thought you said last week.
Thank you.
So we'll
So we don't
reach out to.
just my, are we gonna wait? We're not gonna make any firm decision. We're gonna wait to talk to somebody and, what's her name?
We're going to hear from the sponsor of the bill.
Yeah.
Yep, I just asked Claire's schedule.
Okay. All right.
Great. Thanks, everyone. Thank you, Leslie, for coming on Zoom. We hope to see you tomorrow, but if not, we understand. And we are done for the day. See you back here at 9.